So assuming, just imagine yourself on the D-Day, you are in front of the door. Okay, so this is you in front of the door. I just wanted to get you in that situation. Let's go. So you read the case. After that, you have 1 minute to prepare your mind, and then you open the door, and then you get in, and then the game starts. Dr. Bimbola, you can start.
Okay, I should read the question.
Yes, please.
Okay. Mary Smith, a 40-year-old female, comes to your office because she's feeling fatigued. In the next 11 minutes, please take history and counsel the patient.
Okay, so your 1 minute to reflect starts now. When it's time, I will let you aware so that you can get in. Okay, 1 minute up. So you can enter the room now. When you enter the room, you will see the patient. And then you can start.
Hello.
Hi.
Please, my name is Dr. Abimbola Adewolu. Please, can I verify your name and your age?
You can call me Mary. I'm 40.
Okay. Please, can you tell me when the fatigue, can you tell me how you are feeling?
I just feel tired a lot of the time, basically.
Okay. When did it start?
I would say about 3 weeks ago.
Okay. Do you have any other complaints apart from the tiredness?
Like what?
Is there any other associated complaints like headache?
No.
Okay. Do you feel deep sleep? Do you feel like, do you have any difficulty breathing?
No, doctor.
Have you had this kind of condition before?
No, doctor.
Okay. How severe is it? Is the tiredness you're feeling? Can you do other things? How severe is it?
I would say it's quite bad because I don't really have the energy to do a lot of things lately.
Okay. Is there anything that makes it feel worse?
No.
Or is there anything that makes you feel better?
No.
Okay. Have you been admitted before in the hospital?
No.
Do you have any allergies to any medication?
No, doctor.
Do you have any urinary problems? Any problem with your urine?
No, doctor.
Do you have any problems with your feeding, your GIT? Do you feel like vomiting?
No.
Okay. What of your sleep pattern? Are you sleeping well?
Yeah, I think I'm sleeping more than normal, more than usual.
Okay. Can you tell me about, since you're a lady, can you tell me about your last menstrual period?
Yeah, that was last week.
Okay. Do you have a lot of menses? Excess menses?
It's just normal, doctor.
Okay. Do you smoke cigarette?
No.
Do you drink alcohol?
No, doctor.
Okay. Thank you very much, Mrs. Mayor.
You're welcome.
That's all I have.
That's all you have? Okay, sure.
Okay, I should counsel the patient. Okay, sorry. I just took the history. I suppose you are feeling tired. I think you should have time to rest. Maybe you're working so hard. I think you should have time to rest. And also, I'd like to do some blood work on you. Like, I'd like to check the CDC, complete blood count. I'd like to check for your blood film to see if there are any parasites there. And like I said, I would like to counsel you to rest.
Okay. Thank you.
Are you done?
Yes, I'm
Doctor,
done.
what do you think is wrong with me?
Like I said, it might be because of anemia. That's why I want to do the complete blood count. It might be because of anemia. It can also be because of some parasites in your blood, like malaria.
Is there any medications you think might be good for me now?
Yes, after the blood work and when we have verified the diagnosis, if it's anemia, if it's iron deficiency anemia, I like to place you on iron tablets. And if it's due to some parasites, we like to give you the medication that will treat the parasites, like chloroquine for malaria. Or if it's due to worms, I like to give you anti-helminths that will treat the worms, like albendazole, mebendazole.
Thank you.
I'm done.
Okay, sure. So Dr. Bimbola said he's done. I want to ask, is there anyone else who wants to volunteer for the same case? Because it was supposed to be an 11-minute case. Literally, he's done at 5:47, 5 minutes, 47 seconds. Is there any other person who wants to use a different approach to this case? It's a learning stage, Dr. Bimbola. Don't feel bad about it.
Yes,
Don't feel too good.
I am interested.
Okay, Dr. Bukhari. All right, sure. So, Dr. Bimbola, thank you very much. Dr. Bukhari, are you able to put on your camera and then we'll take it from there? Then after that, we'll give feedback for both candidates. Okay, Dr.
The
Bukhari.
only thing with me, I have small son. Maybe he will like giggle in between.
No, that's fine. It's okay. We get
Okay.
it. Don't worry
Now,
about
can
it.
you see me?
Just lift up your camera a little bit and then I will start again.
Are you able to see me now?
Yes. So I will unpin Dr. Bimbola, and then I will pin Dr. Who is speaking now? Dr.
Sadaf Bukhari. My name is
Dr.
Dr.
Bukhari.
Sadaf.
Okay, sure. Then after that, we compare. You know, it's a learning situation, so that's fine. So Dr. Bukhari, let me just put the spotlight on you. Yeah, and then we'll take it from there, okay? So let's start again. You're going out there. You are the one.
You want me to do 2-minute drill as well?
Yes. Do you want to?
Yeah, that's
Yeah,
fine. I can go. Yeah, I can start from history.
Let's simulate the whole exam and everything, okay?
Okay.
So let's start. Read the case. Dr. Bukhari, can you read your case out loud for us to all hear?
Yes. Miss Mary Smith, 40-year-old female, comes to your office because she is feeling fatigued. In the next 11 minutes, please take a focused history and counsel the patient.
Beautiful. Okay. Your 1 minute is up, so your 11 minutes starts now.
Okay. Knock, knock, knock. Hi, good morning. This is my sticker. Hi, my name is Dr. Sadaf Bukhari. I'm one of the physicians on duty here. Can you please confirm your name and age, please?
Mary Smith, 40 years old.
How would you like me to address you?
Mary.
Hi, Mary. Nice to meet you. How are you doing?
Not so good, doctor.
Okay. Can you please tell me, like, what brings you in today?
I just noticed that I've been feeling very tired lately, and it's not getting any better. I'm concerned about it, and that's why I'm here.
I'm sorry. Can you please tell me how you are coping with that? Is it impacting your life?
Not so well, doctor. I'm not able to do some things that I used to do before. I just feel tired. I don't have the energy to do anything.
I'm sorry to hear that. Let me ask you a couple of questions, and definitely we will make a good plan for you. How does that sound?
Oh,
Good.
tengo la solución.
When did it started, this fatigue thing?
About 3 weeks ago.
And since that time, is it continuous or it comes and goes?
It's been there.
Is there any time duration when you feel more fatigued?
I would say it's all through the day. Maybe
Okay.
especially in the morning, I still wake up feeling very tired.
Yeah. And as the day goes by, then
I still feel tired.
okay, still feel tired. Anything that worsens that condition?
I can't think of anything.
Okay, and anything that improves your condition?
Nothing.
Okay, I want to just ask a little bit about your general health. Do you have fever?
No,
Any weight loss, recent weight loss?
no,
Any lumps and bumps anywhere in your body?
no.
When is your last menstrual period?
That was last week, doctor.
Okay, okay. And is it normal or it was heavy?
Normal.
Normal, okay. And can you want to tell me, do you have kids?
Sorry, doctor.
I'm sorry to hear that. It must be very hard. Definitely. Let me, are you okay? Do you want something? Any water?
No. Thank you.
And I want to ask you a little bit about your past medical history. Are you okay to continue?
Yes, doctor.
Any significant illness in your past?
No,
No. And do you have any suicidal ideation? Do you want to harm yourself or anyone else near you?
no, doctor.
How is your eating habits? Are you able to eat properly?
Yeah, I think I'm eating a little more than normal.
Okay. And how's your sleep?
My sleep, did you say?
Yeah. How's your
Yeah,
sleep?
I noticed that I sleep a lot more than usual.
And after when you wake up, you told me like you are not feeling fresh.
Yeah,
Okay. And it's been since 3 weeks.
yes.
Do you have any allergies?
I'm allergic to peanuts.
Okay. Okay. And any medication are you taking at the moment?
Nothing.
Do you ever smoke?
No,
How about alcohol?
no, doctor.
Any recreational drugs?
No.
How are you being normal? And
What?
how is your urinary habits? Are you being normal?
Yes, I
Any
pee.
yeah? Sorry, I did not hear.
I pee normally.
Okay. Any nausea?
No,
Any kind of vomiting?
no,
Any abdominal pain?
no,
Okay. And any past history of high blood pressure,
no,
high blood sugar?
no.
Okay. And you are not taking any kind of medication at the moment.
I told you no.
Anyone in your first degree relatives have any kind of significant disease that you want to share?
Yeah, my mom had depression.
Okay. Okay. Got it. Got it. And she was experiencing the same symptoms as you are?
Something similar.
Okay, okay. And what do you do for a living?
I don't work right now.
Okay, okay. And then how are you supporting yourself?
It's been very difficult.
I'm so sorry. I totally understand. Like it must be very hard. Here is the tissue paper. And are you able to continue?
Yeah, it's okay.
Definitely. Please let me ask a couple of questions, and definitely we will make a plan. that will help you and you will feel better. How does that sound?
Good.
Whom do you live?
I live alone.
Okay, you do not have any social support, any friends?
Not really.
I'm sorry to hear that. Just to summarize that, like you are experiencing extremely fatigue since last 3 weeks, and in the past you do not have any significant medical history and you are not taking any kind of medication. You are allergic to peanuts and your mom had a history of depression. Am I correct?
Yes.
And you do not have any social support at the moment.
Sure.
Yeah. Smith, I'm sorry to hear that, but definitely it must be hard in this situation to carry everything. Definitely, I would wanna educate you about, like definitely you have to seek medical attention. Did you spoke with your family doctor?
That's why I'm here to see you, doctor.
Oh, okay. Before this, you did not see.
No.
Okay, and there was no past hospitalization?
No.
No previous surgeries as well?
No, doctor.
Okay. First of all, I would like to send some lab investigation that include complete blood count with differentials and to rule out any kind of anemia if there is. And then it most probably looks like you are experiencing depression kind of symptoms, as you have your mother was having that history of depression as well. At the moment, I would suggest you definitely I will connect you with some support, social support services, and I will give you some brochures and YouTubes where you can get an idea what is depression. Depression, basically, it's a kind of mental health problem that is that can be benign or it can be very severe in later stages in its later stages, and you are in the beginning and you are having mild to moderate kind of symptoms of depression. And I would definitely suggest some medication for your symptomatic relief and some medication to relieve your irritability, and that will improve your sleep. And I would want to educate you that you try to eat good, take do
Doctor,
some.
what medications do you want to give to me?
There is a kind of medication that is called serotonin reuptake inhibitors that found most effective in this the treatment of depression, and we will start in the initial stages of depression, and most people get benefit from that. Did you heard about it?
Yeah, my mom used it and it worked for her.
Oh, okay. Yeah, you have any idea a little bit about this medication has some side effects as well. I want to tell you about those, like when you will start this medication, take properly on regular basis and do not stop without the consultation of your doctor. Just give me a second. Do not stop without the consultation of your doctor because it has its own side effects if you will stop abruptly. And in the initial phases, you can be irritable and you can have a little bit suicidal thoughts. So you do not worry. If it will be more and you are not able to cope with that, definitely you should call in my office, and or you can go to ER if that is beyond your scope to accommodate.
How long will I take these medications for, doctor?
At least 6 months to 1 year, depending upon the situation. And that's why when I will start the medication, I would like to follow up with you within 2 weeks to see how you are doing with medication. Either symptoms are improving or not. And depending upon the
time up. Okay, good. So because this is just a counseling case,
my son was.
don't worry about that. We understand, all of us have children around us, so we totally get it. But you were still able to keep your mind even in the midst of all this. So Dr. Bukari, how do you think you did? Dr. Adewolo, how do you think you did now that you've seen the way Dr. Bukari did? And I think Dr. Bassett also wanted to say something. And with the candidates, if anyone wants to say anything, you can bring it up. So maybe let's start with Dr. Bukari. Dr. Bukari, how do you think you did? How was the stress? How was the pressure on you? How do you think you did? Then we'll let Dr. Ola also in her contribution. I want the candidate to talk about how they felt first.
I want to add in counseling something, like I want to refer into the psychologist or psychiatrist, and I want to a little bit like if she actually he is not having suicidal ideation, so that's why it's not to form that patient. And but definitely I would recommend and refer to the psychotherapist for the cognitive behavior therapy. That I can add on that. There is a little drawbacks in the history, but I'm feeling good about that. Like I did, and I got a little bit idea, like because there is a depression in family, and she's experiencing depression kind of symptoms, and that's why she's fatigued.
Okay, sure. Dr. Adelowolo, you know, Dr. Bukari has presented hers. You also presented yours. How different do you think she presented her situation? What do you think you did very well in? What do you think you can work on?
I think Dr. Bukari did better than me.
Okay.
Like then my differential diagnosis was poor. I didn't ask about fever, about weight loss, ill appearing, neurologic deficits. My differential diagnosis was poor. Then I also didn't go to town about depression, about mental illness and all that.
Sorry, your voice is fading. We can't hear you.
I didn't go to town about depression, mental illness and all that. My differential diagnosis was generally poor.
Yeah, and then you're talking about malaria and all that, right?
Yeah,
which is not very common in Canada, by the way. Yeah. And I understand you, like I understand you because I'm coming from where you're coming from, right? Like, and malaria is very common from where we are coming from, but especially in a Canadian context, that's a bit different. Dr. Ola, before I get into breaking the case down, what do you think you saw? What are the things you want to highlight on?
Yeah, thank you very much. I think at least you can hear my real voice now. So
yeah,
now comparing this to what you saw in the scenario, they are totally different, right?
Mm-hmm.
And those are the kind of cues that you want to pick from the SP when you get in. The two of you tried, honestly, for you to come out and take that bold step is a very good thing, which I must applaud you for.
Mm-hmm.
Now we got to be frank and just say it, right? So that we can learn from the process.
Yeah.
I will start with Dr. Adelowo, right?
Okay. Sure.
Yes.
Yeah. So I think from the get-go, once you enter, you want to see whatever it is you are picking from this patient.
Beautiful.
Is she looking down? I'm sure I didn't give you that vibe. Like I didn't give you that, hey, hi, doctor. Yeah, I'm this, you know. There was something really just, this patient was just, so you want to bring that out first. Once you miss the boat from the beginning, honestly, you are going to miss it almost all through the case, right? So you want to get what you are dealing with right from the beginning. So I think that is where you need to work on. And don't fix your mind on a particular diagnosis. You assumed I had anemia. I don't know why. You just assumed it was anemia. So you have to be open-minded. And once you are able to get the full history, like the presenting complaint rights from the beginning, it helps you to know what to ask for, which I'm sure Dr. Bruni will talk about as you go on. So I think those were, and your history was not like, it was all over the place. It was everywhere. You have to know the specific questions you want to ask, depending on the scenario that you are presented with, depending on what you are seeing, the cues the patient, the SP is giving you. There were times I wanted to redirect you, but you were still going back. So just take note of those things. Dr. Bukhari, yeah, I think
Maybe
you did
Dr.
well.
Livin, before we go to Dr. Bukhari, I just want to throw more light on what you just said. In relation to what Dr. Ola just said, by the way, Dr. Ola is one of the people who will be taking you through this course as well. She's a wonderful co-tutor. We run this together, so you'll be seeing her as well in class. But Dr. Ola just said something, and that is one thing I've realized a lot of candidates do. You know, I know that there are a lot of resources in the system, and all of them are good, like no problem with them. However, what I've seen candidates increasingly do, like what Dr. Ola said, was that we at times think that we have to just go through a set of questions. And the whole presentation then moves from a conversation to I have these set of questions I need to take the patient through, no matter what the patient is saying. So you realize that Dr. Ola was directing the conversation somewhere, talking about herself, right? And then I don't think in real life we sit in the clinic saying anyone who comes in with fatigue, anemia, malaria, you know, you just let the patient flow. You let the patient flow. Secondly, there were times Dr. Ola was trying to cry. Dr. Adewolo, are you listening? There were times
Yes.
Dr. Ola was trying to cry, which you should have, oh, you are crying. Can I get you tissue? I think Dr. Bukhari did that a little bit. I'll let Dr. Ola talk about Dr. Bukhari, and then we will look at it further.
Yeah, so thank you. So for Dr. Bukhari, yeah, I think, yes, she did well. I would just like to point out some things. Okay. Because when you get some cues from the patient, follow it through to the end, so that it helps you to clinch your diagnosis, even though you already kind of like figured out this was depression at one time or the other. There are still some pertinent things that you needed to ask to be sure that it was like depression. What happened prior to, I said it happened 3 weeks ago. Is there anything that precipitated that? You know, did you find out if there was any stressor in my life? Because I would have given you some stories before that happened. You want to at least dig deeper into whatever it is. I'm sure Dr. Brony will talk about the MCH caps. You already had a feeling it was depression, but remember, there's a criteria you must fulfill before you start making the diagnosis of mild to moderate to severe depression. So you need to go through that. And also that fatigue, I didn't see any of you like fully go into getting the history of that presenting complaints to explain what that fatigue is. Is it just tiredness? Do you wake up just feeling tired? Is it your energy? It's like you need to ask more questions to know, and that would redirect you. I tried explaining that to Dr. Bukhari, I remember, because I was telling you I sleep well, and despite that, I still feel tired during the day. My mood was low, I was down. Nobody mentioned my mood. Have I lost interest in things I used to do? I don't have friends. I don't have a job. What happened? You want to show that you are patient-centered. You care. It's more than just offering the tissue. It's a good thing to offer that, which you did, which was good. But you know, you really want to show that you are empathetic to the patient. You want to know more, and that would help in your counseling, because you won't just address the depression. You want to see if there's any other services you can offer while you are doing your counseling to help the patient as well. So I would rather appreciate that you go through the MCH caps very well. And then I told you I was eating more. I know you ruled out constitutional symptoms, but you know, in an attempt to rule out constitutional symptoms, remember that appetite, weight changes is also part of the symptoms of depression. So you want to know, it's not just weight loss. Am I gaining weight? I would have told you yes. And that will make hypothyroidism one of your differentials as well, which you need to rule out. So it's not just about getting the diagnosis. You also want to rule out some like red flags. You did the constitutional symptoms, which was good, but also you want to see any features of hypothyroidism at all. And that will be part of your differentials as well. So you should let me know in your counseling, you examine me, you know, and then you can send me for some blood work that will help. But you did well, you still counseled me, which I appreciate. And also the family history also gave you. Something you might want to ask, how is your mother doing? You know, just to show that you still care. How is she now? Just 1 or 2 questions about it, and you'll be good to go.
Sure.
Well
Now,
done.
thank you very much. So these are the things we are picking up. Now, Dr. Bassett, you've raised your hand. Dr. Bassett, what do you want to say before I come in? Because I want to point to some specific things, and I've seen that some people also sending me some private messages as well, and I'll address them. Dr. Bassett, please, let's go.
Yeah, are you able to see me? Hi,
yeah,
doctor?
we see you. Yeah, please.
Yeah, actually, I just want to add something for the history. I saw the patient, and the patient was all the time in the low mood. And so I was about to ask in the history that about the lack of whether she's having an interest in the activities, daily activities, like, going with the friends or going somewhere, or like, is she happy? Sometimes she feels happy, or all the time she feels like low all the time. So I would go for the differential diagnosis of depression by asking these questions. Yeah.
Beautiful.
Yeah, and then I will ask her in the first that we will have a patient and a doctor should have a bond of confidentiality, like we will share a bond of trust, so she can share with me anything. So she should be easy and comfortable. The patient should be comfortable to share anything with the doctor. So they should have a bond of mutual cooperation and mutual understanding. Yeah.
Now, thank you very much, Dr. Bassett. In fact, that's very important. You realize that the face of the NAC OSCE has changed. And when I say, okay, sure, Dr. Ali, please speak. Dr. Ali, you want to add something, please speak. I like the way people are bringing contributions. Please bring your contribution, Dr. Ali. Hello? Dr. Ali, you wanted to say something. You said, may I add something? Okay, maybe while Dr. Ali tries to get himself ready, I want to say this: the face of the NAC OSCE has changed. But when I say it has changed, what I mean is that it has moved from, your knowledge in a case where you just come in, okay, you have headache, you have this, you have that, to more of a communication-based exam. Communication. And one of the things you want to pay attention to in your communication is what we call signposting. Signposting. For example, oh, I'm fatigued. Okay, Mrs. Smith, I want to ask you a few more questions about the fatigue. You know what? You've put a sign there. And that sign is basically to help the patient to know that at this point in time, this is what we are focusing on. And then maybe as you are moving on the history, you don't go, oh, do you just have any past medical history of any conditions? No. You rather say, I want to ask a few more questions about your past medical history. You realize that when you start using words like that, the examiner realizes where you are going so they can follow you. Because don't forget, you want to do everything possible to get the examiner's attention. Please, are you following me? You want to do everything possible to get the examiner's attention so that the examiner follows you. The examiner is a human being. The examiner may miss some points you are going, but if you signposts, and I will show you what signposting is very soon. So these are things you want to look at. So I don't want to take your time, but I just want to bring up the approach. So you introduce yourself as you did. You give your sticker, you shake hands, depending on the COVID regulations, which they bring up. You review and analyze the chief complaint. That was what Dr. Ola was talking about. Take your time with the chief complaint. Take your time. Don't just say, oh, fatigue. Okay, sure, fatigue. What is it? What's happening? No, it could be a psychological issue. It could be a cancer. It could be hypothyroidism. It could even be, it could be anemia. It could be so many things. So you want to then take your time to analyze this very well. And we use the approach of onset, the cause, and the duration. And that is why Dr. Ola was saying that it is good that you take your time to analyze even the patient's situation, even before that, the fatigue started, so that you know what was the patient's baseline before all these things started. How is it going? Is it getting worse? Is it getting better? What time does it get worse? What time does it get better? What makes it worse? What makes it better? You know, what has the patient done in the past about the situation? These are all about the fatigue. We've not even gone into any other thing yet. All right. And then the duration. Has this happened before? Because there are some conditions where things can happen, the patient can get better, it can happen again. Okay. And then you want to even probe further. What does the patient mean by being fatigued? Because various people have, is it shortness of breath? Or is it just fatigue? Is it that she gets tired after activities, which almost everybody will get? Or is it that she does not even have unrefreshing sleep? All right. Is it after rest and sleep? How has it affected the patient's activities? Because you know what? What does the patient love to do? And how has this fatigue affected that activity? Is the patient just having decreased energy to undergo activity? Or the patient is able to undergo activity but feel so tired that they cannot complete it? All right. And then this was what Dr. Ola talked about. Pick up the picture. The patient was looking down. The patient's voice was low. You should be, if you don't pick up that picture, in the exam, the patient may not give you the information you want. So for example, if you get into a room and the patient is walking up and down, you've got to pick the picture. Don't just say, oh, the patient is just walking up and down, therefore I'm going to take my history. No, you've got to say, oh, I see that you are a bit, you know, you are moving up and down. Is there a way you can calm down so we can talk? So that is the issue of picking up the picture. This patient was sad. This patient at a point in time was even crying. And you've got to know that you've got to pick it up, you've got to be able to pick it up. If the patient looks pale, you've got to be able to pick it up. If the patient has any stress in the life, maybe the patient is sitting down, the patient is constantly looking behind her back because the patient is afraid of something which is about to happen, you've got to pick that up. Okay. Now, so look at this. This is on the fatigue alone. You don't rush it because you are doing patient-centered care. You are not coming with a bunch of information. Look, this is what I have. Look, you can have somebody who knows everything. And you can have somebody who goes into this exam very empathetic, decreases the tone of the voice, takes the time to probe further. And you'll be surprised that that person who takes the time to probe further as compared to this other person who says, I know everything, I know the differentials, I know the person who is taking their time to probe further may even come across as doing better than, because the person will say, oh, I had my diagnosis. No, the exam is not only about having the diagnosis. It's about the approach you use to get to the diagnosis. Okay. All right, Dr. Albedini, let me finish, and then after that, you come in. Beautiful. Now, in a patient with these symptoms, things you want to look out to be depression, dysthymia. But of course, dysthymia would have been if the patient has had this and it's not really affecting activity for more than 2 years, right? So this is obviously not it. But you even want to find out about bipolar disorder, because with bipolar, there are times when the patient's mood is low and there are times when the patient's mood is high. So even though the patient is telling that, oh, my mood is low and I'm tired and all that, you also want to find out, are there times when you have increased energy? You want to find out about that. And then you want to move into organic causes like hypothyroidism. So are you losing hair? Has your skin become very dry? Have you noted that you are not able to pass stools as regularly as you should? Do you feel cold when all other people feel warm? And you realize that all these questions I'm asking, I'm not using any technical jargons. Like, do you have any heat intolerance, cold intolerance? No. Rather, do you feel cold when all other people feel warm? Do you have to wear more coverings when people are wearing just t-shirts? You see, it's the same thing about cold intolerance, but look at the way it is being put. You have to use patient-centered language. And that is what we want to emphasize on as you prepare for this exam. As I said, yes, you know the differentials, but how are you going to put your questioning? You've got to review anemia, because anemia can also lead to fatigue. You've got to review diabetes. All right. So that is what we're talking about. So your main differential, or one of your key differentials, is MSH caps. Some also say MI pass ECG. However you want to arrange it, that's fine. Okay. So you want to review the patient's mood, the patient's interest. Is the patient getting any psychomotor agitation? Do you easily get angry? You put it that way. How is your diet? How is your appetite? Are you eating more? Are you eating less? Don't forget that decreased appetite and overeating or eating too much are both signs of depression. Okay. How is your sleep? Depression can present with decreased sleep, more sleep. Any thoughts of harming yourself? If the patient says yes, then you, aside this MSH caps and MI pass ECG, you want to add on sad persons as well. But if the patient does not talk about, no, I don't have any thoughts of suicide, don't probe further. That is the other beautiful thing about this exam. When the patient says no, it means no. The patient is not trying to trick you. How would you describe your energy? How would you describe your energy before this fatigue began and your energy right now? What about your concentration? Any feeling of guilt? Has there been any unique situation in your life which has brought this issue up? Now, another thing I realized was that some of the, I think one of the candidates was asking at times 2 questions at a time. That doesn't help, because I remember Dr. Ola was asking the candidates, which one or what do you mean? When you start doing that, you know, it's like you are trying to rush through the case, but you realize that Dr. Bukari had quite some time to go through her case, okay? So don't try to say, do you have any cough, any nausea, or any vomiting? The patient will ask you, which of them do you want me to answer? And then that will not be very good for you. Then you go into anemia as well. So is there any shortness of breath on exertion? Any heart racing? Don't say palpitations. Any heart racing? Or do you feel your heart beating in your chest? Any headaches? Any chest pain? Because anemia can present with angina. Is the fatigue worsening, or is it the same? Have you noted any dark stools? Why? Because you want to check out for any GI bleed, any heavy menstrual flow. If yes, how many parts do you use? Is it different from the number of parts you were using before the fatigue started? Doctors, please, are you seeing how we are probing? So it's not, I don't know how to put it, but it's not just a lot of medical jargons, but you're having a conversation. Make it a conversation so that you are so smooth that the patient does not even realize that you are actually having a conversation with them. Hypothyroidism. Are you feeling cold when all other people feel warm? Any neck swelling? What about a change in voice? Is there any dryness of the skin? Any hair loss? Any decrease in bowel movements? All right. And then probe further into bipolar. Because as I said, bipolar 1, bipolar 2, they have some depressive components. So it could be that the person's mood is low, the person is fatigued, and the person is in the depressive state of bipolar. So ask, you know, have you been staying up late, you know, maybe working more on your laptop? Are there times when you feel that your energy is higher than how you are feeling now? Have you engaged in any unnecessary buying? Diabetes, is there any history of increased urination, lots of urine, you know, increased tests? And then you even want to rule out other things like psychosis. So you want to touch base on some hallucinations. Do you see things other people don't see? Because don't forget, this is an 11-minute case. So don't rush through it. Take your time and, you know, dissect and walk through the thing. At the same time, following the clues the patient is giving you. Because if you don't do that, it's like you came in with your own agenda and you forget about the patient's agenda and you are just doing your own stuff. All right? And then rule out suicidality, but don't only rule out suicidality, rule out homicidality. Do you have any thoughts of hurting yourself or other people? And then if you want to be very pinpoint on that, do you have any gun at home? because that is the most lethal form of suicide we have in Canada. You have a gun. And then now go into your B symptoms quickly. Touch base on it. Any night sweats? No. Any unintentional weight loss? No. Any lumps and bumps on the body? No. All right. And then quickly review your symptoms. Like, now I want to ask you some questions about your general health. I want to start with, any headaches, any visual blurring, you move, any quick, maybe one question per system. Fast. You don't waste time there. But you want the examiner to know that you are doing your review of systems in a very stylish way. Please, are you following me? Now you go to your general questions. Any past medical history, liver disease, kidney disease, any past psychiatric history, because you are looking at depression as one of your differentials. So you want to mention it. Any past surgical history, allergy history, family history of psychiatric conditions, and your main diagnosis you are thinking about. And this patient said that her mother had depression. In fact, you should even ask what kind of medication the mother took. And I know Dr. Bukari asked that question. And when the patient tells you, oh, my mother took a medication called sertraline, it has been found out that people, in the same family can at times respond well to a particular condition. So for example, a particular medication. So for example, if you have a sister who had depression and your sister did well on sertraline, most of the time when the patient comes in, maybe, doctor, I want the same medication my sister took, if that is the direction you want to go. So through this, you are already finding clues when it comes to your management and your counseling. Okay. And then you go to the social history, because this is depression you are dealing with. So you want to talk about smoking, alcohol, illicit drug use, work situation. Because it could be that the work situation is what is causing the patient the depression. Maybe she has a boss who is always on her issue. Or maybe she has, a toxic work environment. Because this a psychiatric case, don't play with social history. If you have a psychiatric case, don't play with social history at all. Family stresses. What about the supports in the community? And even ask about religious and spiritual support, because when it gets to your counseling, if this patient has religious leanings, you want to, call on that. You want to involve all those resources in the patient's management. Now, this is one part a lot of candidates miss. We call it fiving the patient. Never, ever, ever, unless maybe it's like an emergency case that the patient is unconscious. But if it's a patient who is talking to you, please don't forget to five the patient. Write it down. Write this down. This is a trick a lot of candidates don't know. Mrs. Smith, what is happening? How do you feel about it? Doctor, don't only think that you are the one who knows medicine. The patient might have done some reading. The patient might have done, some research. In real life, that's what happens. What do you think is going on? What do you think is, how do you feel about this? Well, doctor, I don't know. Maybe I read that it could be my thyroid. Because, you use this 5 because it gives you pointers about what to emphasize on counseling. Because the 5 will tell you, maybe the patient is having anemia, but the patient thinks that, oh, it is her grandmother's voodoo, which is doing her situation. So you use the 5 to help you to open the door so that you can be able to know the things you have to debunk and the things you have to stress on when you're counseling the patient. And it opens the door and gives you a better perspective about the patient. Because if you are thinking about something different and the patient is also thinking about something different, the 5 will help you. So the F stands for feeling. How do you feel about this condition? What are your ideas about what may be possibly causing the fatigue? Okay. Are you able to carry out your daily activities? That is function. So you don't go asking that, what is your function? No. You don't go say, what's your feeling? What's your idea? No. What do you think is causing the cease? Ask it in a nice, sleek way. The patient will not even see that you are fiving, but in reality, you are fiving. What are your thoughts about what is happening? Are you able to carry out your daily functions? That is function. Expectation. Mrs. Smith, what do you really wish I can do to help you today? Because, for example, you may be thinking about giving this patient SSRI. The patient may also say that, no, I don't want any medication. So that means that in a patient whose expectation is that in the management of her depression, you don't give her any medication. If you just start throwing SSRIs at her, you are missing the point. Please, are you getting me? So the 5 helps you to organize yourself so far as management is concerned, because you get somewhere and say that, okay, Mrs. Smith, I realize that you told me that with everything going on, even though we don't know the diagnosis, you want us to find out what is exactly going on before we put in any medication. Is that right? The patient will say, yes, doctor. In fact, I want to hold on with any medication until I know what is going on. Then you can, what we call it, a therapeutic agreement. You can have an agreement with the patient. Because the most painful thing is for you to be thinking about maybe a particular therapeutic plan, and the patient also has a different therapeutic plan. That will be very, very tough. And that means you're not listening to what the patient is saying. So then you summarize and hit on significant positives and negatives. So, Mrs. Smith, you've told me that you're having decreased energy and fatigue for the past 5 months or 4 months, and it's been the same. And you have a strong family history of depression, and your mother did well on antidepressants. You also tell me that you don't have any shortness of breath. You've not seen any increase in your menstrual flow. You've not noticed any dry skin or loss of hair. Well, this directs me in a particular way. However, before I can come to that conclusion, I want to do some blood work. You see the way I'm introducing everything? You don't just say that I'm going to do some blood. No, you hinge the blood work you want to do. You hinge it upon a premise, and that premise is the summary you want to do. So I see that you have this, you have that, but from the history and from what you told me, you don't have this, you don't have that. Based on this, I'm going to request these investigations, and that will help me to clearly understand the picture. And then, Mrs. Smith, with what I told you, have I missed anything you want me to know? So you give the patient another chance to clarify points for you. Anything I've missed that you want me to know again, and then you thank the patient and you introduce your counseling. So you see, there's a lot to be done in Lavem. Dr. Bassett, are you there with me? I can see you're listening very well. There's a lot to do so far as counseling is concerned. So it's all about, teasing things out and then introducing your concepts gradually. Don't let the patient feel rushed. So Mrs. Smith, with all you've told me, I think you may have a condition called depression. Someone may ask, what is depression? Peaceful. When you do it that way, the patient goes like, "Ooh, this doctor is really listening to me." So depression is an illness that causes you to feel sad, lose interest in activities that you've always enjoyed, and withdraw from others and have little energy. Mrs. Smith, are you there with me? It is different from normal feelings of sadness, grief, or low energy. In fact, with the conversation we've had, I don't think I came across anything which tells me that you are going through any grief. Depression can also cause people to feel hopeless about the future and think about suicide. It's all about language. The NAC OSCE is about language. It's about language. What's SP? SP is like what Dr. Ola did, like the patient you'll be talking to. That's the SP, okay? Good. So many people, and sometimes their families, feel embarrassed or ashamed about having depression. Do you know what we are doing here? What we are doing is that we are normalizing depression for the patient. We are trying to let the patient know that you shouldn't feel weak for having depression. Don't let these feelings stand in the way of getting treatment. That also is another statement which is helping the patient to know that, oh, I can get treatment and I don't need to feel weak about it. Remember that depression is a common illness. So what you are doing is that you are demystifying depression for the patient. It affects the young, it affects the old, men and women, all ethnic groups and all professions. So, so that means doctors can get depression. Yes, Mrs. Smith. That means policemen can get depression. Yes, Mrs. Smith. If you think you may be depressed, you can let us talk about it. Do you know what you've done? You are not telling the patient you are depressed. You are rather letting the patient know that I want to open the door for us to talk about depression. Do you give me permission for us to do that? So treatment can help you enjoy life again. So now you are letting the patient understand the benefit he or she will get if they adhere to your therapeutic plan. The sooner you get treatment, the sooner you feel better. Okay, so what causes depression? It's a disease. It's not caused by personal weakness, and it's not a character flaw. When you have depression, there may be problems with activity levels in certain parts of your brain. So you see, we are talking about the issue of serotonin, but you're not using the word serotonin. You are using the layman's expression, okay? Or chemicals in your brain called neurotransmitters may be out of balance. Most experts believe that a combination of family history, that's the mother, and stressful life events may cause depression. Life events can include death in the family or having long-term health problems. Just because you have a family member with depression or have stressful life event doesn't mean you get depression. And that is why we are going to do the investigations. You may also get depressed even if there's no reason you can think of, okay? So how is it treated? You see the stepwise approach? How are we going to treat it? It can be treated in various ways. Mrs. Smith, from what you told me, it looks like you don't want medication for now. So we can try things like counseling, psychotherapy, antidepressants. However, now you can let the patient know that if their non-medication approach fails, medications can be used. Lifestyle changes such as getting more exercise may also help. Work with your healthcare team to find the best treatment for you. It may take a few tries. So you're letting the patient know that they can fail on an antidepressant, but you can try something different. And it can take several weeks for the medicine and therapy to start working. Try to be patient and keep following your treatment plan. Depression can relapse. How likely you are to get depression again increases each time you have a bout of depression. Taking your medications and continuing some types of therapy after you feel better can help keep that from happening. Some people need to take medicine for the rest of their lives. This doesn't stop them from living full and happy lives. So you see, even though you are saying they may have to be on their antidepressants for a long time, you are still giving them hope. You are being empathetic. I have a question. Even though this is preparation for an exam, if you went to a doctor who spoke to you this way, wouldn't you like him to be your family doctor all the time? Hello? Wouldn't you like that doctor to be your family doctor all the time? Because the person has,
Yes.
the time to, explain. And that is exactly what a NAC is all about. So I think forgotten the name, Dr. Albedini wanted to say something. I don't know whether you want to still say, yeah.
Yes, hi. It's thank you so much for having us tonight. It's very helpful to get your insight.
Mm-hmm.
So we're definitely learning from both approaches. So I think that the secret sauce for success in NAC, it is listening to the patient when you walk in. I know that you have a bunch of things running in the back of your mind. You want to ask every single patient a million questions,
Mm-hmm.
but that could take you to east instead of west.
Exactly.
So it's very depressed there. So ask her, how are you feeling? So she's giving you a clue. So don't leave that lane and go to other lane. So if we look at the first candidate, he did well. It's a trial. It's awesome, and all of us who are learning here tonight. But I feel that the first one may be out of anxiety or anything else that could be running of his mind in the first time, and he made a quick decision. And my advice is don't just make a quick decision if you are running out of time, because it could be the wrong approach or wrong diagnosis, and you may give or risking the patient. This is one. For the second case, she figured it out from the first maybe minute or two by having a low mood, but she didn't diagnose the depression. So the looking at those two scenarios, I find forgetting everything and just look at your patient. This is how we're gonna get to the a good score, and this is what's gonna make you a good doctor. So just look at the patient, forget everything else. You don't have to ask like every question to the patient, and then at the end, a follow-up will be a good one, especially with the depression patient. Them involved in decision making. Have I been able to solve your question for the day? What do you think about this? You know, by throwing those open-ended questions, sometimes you get some clues, right? Yeah, so this is just what this is what I want to add. I don't want to repeat what you have mentioned. It's great. This is just like a quick
yeah. And I'm very happy that candidates are realizing this, because what I've seen a lot of candidates do, and don't get me wrong, you need a strong medical background to pass the NAC. You really do. However, you also need a very, very empathetic heart to pass the NAC as well. You do. And it's not about, you know, how do I say this? Like throwing a bunch, like what you were saying. Because if you're not careful, you just throw a bunch of questions, and by the time you realize you're on lane 2, while the patient is really talking about lane 1. And you say that, oh, but I got my diagnosis right. Why did I get this mark? Because you probably were not following the patient's cues. Okay, so I'm just trying to round things up for the discussion we're having, and then I'll open things up for questionings. Okay, so we can also start you on antidepressant, medications called antidepressants. It's also possible that while you start these medications, you may feel like hurting yourself. I remember Dr. Bukhari said that, oh, when you start the medication, you may have suicidal thoughts. Sure. What should the patient do if they have suicidal thoughts? In case you have that feeling, I will give you my office number. You can call 911. And then the other thing is that I want to follow up with you. So I'll need to put you for a follow-up appointment in 2 weeks after starting the medication. Mrs. Smith, is that okay with you? Yes. Mrs. Smith, do you have any questions? No. Mrs. Smith, are you able to summarize all that I've told you? You see, you are getting the patient to agree with you gradually as you go on. And by the time you realize you formed a wonderful therapeutic arrangement with the patient. It's not about a bunch of words you use, but it's about the approach you use for the exam. And that is exactly what we want to prepare you for and want to get you grounded in. Because, yeah, then the face of the NAC has changed. Look, you can sit at home and cram all the various materials in the system. All of them are good, but it's about approach. You need to be guided. That's the truth. You need to be guided. And then the other thing is that learn to give the patient gifts. When I say learn to give the patient gifts, I'm not saying give gifts to the patient, but learn to give the patient handouts. So Mrs. Smith, before you go home, I will tell the ladies at my front desk, or I'll tell my office assistant to give you some handouts on depression so you can read it. I'll also print out some handouts for you. Is that okay with you? And if you have any question reading them, please don't hesitate to touch base with me. All the time, invite the patient to always touch base with you again. Give the patient gifts. When I say gifts, what I mean is give the patient handouts. I want to give you this handout so that you can do some more reading. Is that okay? Good. So that is it. We are about to start our NAC class, but I think somebody asked the question. Somebody asked the question, which I want to address before I continue. The person asked the question. Dr. Hella said, Dr. Brony, sorry, I have the same problem as before with my microphone. My question is how to organize the 2 minutes allocated for the reading of the case. For example, how to organize our notes. Sure, And that is something we'll be teaching very well. So you realize that there's an approach. And when we were dealing with this case, we used a particular approach. Okay, the patient has fatigue. How am I going to go through it? What is my OCD, like onset, cause, duration? What are the differentials of fatigue? You can't write everything in those 2 minutes. And what we do in our training is that we do our best to move you away from writing a lot on your paper. We do a lot of, because what I've seen is that a lot of candidates write a lot on their paper and they become glued to their paper. So by the time you are done with the training with us, you'll be throwing your paper away and you are just dealing with the patient. You are just having a conversation and you are just talking through with the patient to know exactly what is going on with the patient. All right, sure. So counseling, number one, whenever you're counseling somebody about a condition, you want to know what is the condition about? What is heart failure? What is myocardial infarction? What is stroke, right? First, you want to address that, but use layperson's language. Number two, after you've done that, number two, normalize the situation. Let the patient know that people have that condition. People have that condition. It is a common condition, okay? Number three, let the patient know if it is something which can be managed. Let the patient know that we can still manage it so that you can enjoy your life. For example, the patient has rheumatoid arthritis. We can still enjoy it so that we can still manage it so that you can enjoy your sporting activity. All right. Number four, you want to talk about the pathophysiology of the condition, but with layman's terms. If the condition has family leanings or genetic predisposition, you want to talk about that. Okay. And then you also want to talk about treatment options. When you're talking about treatment options, start from non-pharmacological and then go to pharmacological. And even with depression, you can even talk about electroconvulsive therapy. That is if the non-pharmacological and the pharmacological options don't work. Then talk about what if the treatment fails? What if the treatment fails? And there are some conditions that you can say, if the pharmacological and non-pharmacological approaches fail, we can do surgical approach as well. Not depression anyway, but there are some conditions like that. And then you can also talk about complications if they are not treated. Then you come to, are you okay with me? Can you summarize everything? So before you go, I want to give you this handout. I want to follow up with you. If you go and you have any questions, I want you to chat this with me. That is the simple outline for your counseling. All right? Good.